We're going to talk today about the lateral meniscus. Now, first we will talk about the normal lateral meniscus, its anatomy, function, the biomechanics, and microstructure, which are important concepts to know before we start looking at pathology. The menisci, as you know, are partial discs which are composed of fibrocartilage, and these discs are interposed between the articular surfaces of the femur and tibia. They are crescent-shaped and serve to make the condyles of the femur and tibia congruent. The femoral condyles are larger than the corresponding tibial condyles. They are also rounder, where the tibial condyles are flat. The menisci serve to deepen and enlarge the articular surface of the tibial condyles. When you talk about the structure of the menisci, they are composed of collagen and cells of fibroblastic and chondrocytic origin. 75% of the body of the menisci consists of water. Now, the organic matrix of the meniscus is composed of collagen, mostly type 1, and these are oriented in a very, very specific fashion. The most superficial fibers are arranged along the circumference of the meniscus and follows the periphery. The deeper fibers, which form the bulk of the collagen in the meniscus, are radial and are interwoven with the circumferential fibers. Another thing to remember is that menisci are biphasic structures and will become evident to you as we talk about the application of this particular concept when we're looking at injury. It consists of a solid phase, which is proteoglycans and collagen, and a liquid phase, which is water. Now, look at the tibial attachments of the menisci. On the anterior side, you see that, or along the anterior aspect, you will see that the medial meniscus is anterior to the attachments or the anterior horn of the lateral meniscus. And posteriorly, it's the posterior horn, which is more posterior than the posterior horn of the lateral meniscus, which means that the two horns of the lateral meniscus are in close proximity with each other, giving the lateral meniscus its characteristic circular configuration. Now, it's also important to look at the movements of the knee in relationship to the menisci. The movements of flexion and extension take place above the menisci. The movements of rotation take place below the menisci. Important to look at the popliteus, which consists of two halves. One is attached by tendon to the femur, and the other is attached by an aponeurosis to the lateral meniscus. The popliteus, when it contracts, it serves to rotate the knee and pulls or retracts the posterior arch of the lateral meniscus so it is out of harm's way. What about meniscal movements? The movement of the menisci during flexion and extension is largely dependent on the attachment sites of the menisci. A hypermobile meniscus is believed to be a serious cause of knee joint pain. Now, let us look at this. The lateral meniscus is more mobile than the medial. Both the menisci slide posteriorly as the knee is fixed. Because the lateral meniscus is more mobile, it may move as much as 1 centimeter during flexion. The anterior horns of the menisci are more mobile than the posterior horns. During anterior-posterior movement of the menisci, which occurs in the sagittal plane, the menisci serve to compensate for the incongruous surfaces of the condyles. This movement also prevents the menisci from becoming entrapped. Meniscal movement occurs to some extent in the coronal plane as well. This is during flexion, but it is limited, so that load bearing can be effective during flexion. There is also a component of radial displacement or movement in the coronal plane during flexion. Going back to the previous slide, please remember how these movements occur because they are important in assessing the injury to the meniscus. Now, what about the vascular supply of the menisci? The vascular supply is age-dependent. In the adult, it is the peripheral 3 millimeters of the menisci and the anterior posterior horns, which are very well vascularized. But as you go more inward or medially, there is less vascularization. So what is commonly understood is that the degree of vascular penetration is only between 10 and 25% of the width of the lateral meniscus. Where does the blood supply come from? It comes from the lateral and medial geniculate arteries and their branches. These vessels supply the meniscus through a vascular synovial covering of the anterior and posterior horn attachments. They arborize and form a perimeniscal capillary plexus within the synovial and capsular tissues of the knee joint. The lateral meniscus in front of the popliteus tendon is completely avascular throughout its width. The vascularity of the synovial tissues is important to remember when one is considering meniscal healing. And you know this is true because when you rasp the tissues there, you can stimulate vascular overgrowth into the menisci and cause migration of pluripotential mesenchymal cells, which will promote healing after meniscal repair. When we had talked about the medial meniscus, you might remember that when the meniscus is completely removed, it causes osteoarthritis. If the meniscus is replaced by a graft, whether autologous or artificial, you can never really replace the actual function of the meniscus because the attachments are not exactly the same as in the normal meniscus. Now let's talk about the nerve supply. Most of the nerve supply in the menisci are associated with vessels. The smaller nerves and axons run radially in convoluted patterns. Single axons run through the perimeniscal tissue and are seen in the interstitial tissue of the outer one-third of the meniscus and the horns. The inner two-thirds have no fibers, just as they don't have any vascularity. Now, we have to consider the exposure and vulnerability to injury. You must also remember that when you're considering that the inner two-thirds have neither vascularity nor a nervous supply, the proprioceptive function is accomplished by the outer one-third of the meniscus. Now, the effects of rotation on the knee joint on the menisci are very dissimilar. The medial meniscus, the horns move with the tibia. The intervening arch moves with the femur, so that there is distortion which makes the medial meniscus more prone to injury. What about the lateral meniscus? The lateral meniscus follows the condyle of the femur by virtue of the ligaments of Humphrey and Risberg, as well as the popliteus, making it relatively immune from injury. Let us consider the functions. When we discussed the medial meniscus, we had gone over the functions, but let's reconsider it now. This transmission of the load, particular to the lateral meniscus, we're not going to be discussing the medial meniscus. 70% of the load in extension and at 90 degrees of flexion, the lateral meniscus transmits 85% of the load at flexion. The ability to transmit load comes from the shape of the menisci, which bridge the incongruity between the spherical femoral condyles and the flat tibial plateau. So when a partial meniscectomy is done of the inner one-third of the meniscus, it decreases the contact area by 10% and increases the peak load by 65%. However, when you remove the entire meniscus, the contact area is decreased by 75%, but it increases the peak load by 235%. Now, what about shock absorption? Menisci function as shock absorbers under compression. In order for the meniscus to provide a protective function, structural integrity and continuity is imperative. Loss of the menisci results in 20% reduction in shock absorption. What else does the meniscus do? You will recall when we were talking about the structure of the meniscus, we said that the meniscus is biphasic. This is important for joint lubrication. With compression, water is forced out of the menisci and into the joint space. When the compression is removed, water is reabsorbed. This sponge phenomenon not only dissipates the force, but it also circulates cellular nutrients. And we talked a little bit about proprioception. When the menisci are removed, proprioception is gone, so that the patient without the meniscus is unable to feel the position of the meniscus as well as the normal person would. The function of the lateral meniscus, to reiterate, is as follows. With loads of greater than 150 kilograms, the lateral meniscus bears most of the load on the lateral portion of the knee joint. In contrast with the medial meniscus, where the load is borne equally by the meniscus and the exposed cartilage. At zero load, the contact primarily occurs on the menisci. At 0 degree of flexion, the contact occurs along the lateral aspect, and at 90 degrees, contact shifts to the posterior lateral aspect of the meniscus. Contact also occurs along the medial tibial spine. The area of load bearing is greatly increased, and stability of the knee joint is enhanced by the menisci. Now, the ligamentous attachments of the menisci are important to remember. There are 4 ligaments which connect the meniscus to the other. As you will recall, there's the anterior transverse ligament, which is present in 60% of patients. And then posterior transverse ligament is much less common and present between 1 to 4%. The oblique menisco-meniscal ligaments should be paid attention to because they can be mistaken for a bucket handle tear, and we will see example of this. Meniscofemoral ligaments connect the lateral meniscus to the intercondylar region of the femur and is usually associated with the posterior horn of the lateral meniscus, forming the ligaments of Humphrey and Risberg. Humphrey is located anterior to the PCL, and ligament of Risberg is located posterior to the PCL. Then you have the popliteo-meniscal fascicles, otherwise called the popliteo-meniscal ligaments. These are struts of the lateral meniscus which surround the popliteal bursa. Finally, you've got the meniscal fibular ligaments. Obviously, you don't have the same on the medial side. Now, I projected this so that you can see the connection between the medial meniscus, which is on your right-hand side, and the lateral meniscus, which is on your left-hand side. And you can actually see the way these two are connected. The anterior ends of both menisci are connected by the transverse ligament of Winslow, and the thickness varies considerably. The coronary ligaments are the thickened portions of the capsule connecting the periphery of the meniscus with the margin of the head of the tibia. There is also a very firm attachment between the medial meniscus and the ACL, which is not there in the case of the PCL. Again, continuing with the menisco-meniscal ligament, here is an example of the menisco-meniscal ligaments as they go from the anterior end of the anterior horn of the medial meniscus to the posterior horn. You can see here where there is a bucket handle tear, it could easily masquerade as Barco's ligament or the menisco-meniscal ligament. The menisco-insertional ligament, which we had discussed before, are very, very important. These insertional ligaments protect the transition between the hard tissue of the bone and the soft tissue of the meniscus. Because they are biomechanically different tissues and are prone to mechanical failure, these emphyses or insertional ligaments are very important. Now, what are you looking for when you're looking at the lateral meniscus? Normally, this is a cartoon which shows you the positioning or the optimal positioning of the lateral meniscus. And then, this is on the coronal view, and then on the lateral view, again, you see on the right-hand side of the screen the position or the bow tie appearance of the horns of the lateral meniscus. What do you look for when you look at the meniscus? We look for to see if the meniscus is intact or is there a tear. Do we have abnormal signal intensity? And is this seen on more than one view? Is there an abnormality in contour, such as an altered shape, truncation, blunting, flattening, and rounding of the inner borders? And is there any menisco-capsular separation? Those are the features you need to look for. What does a lateral meniscus look like normally? Here is a lateral image of the lateral meniscus showing you the classic bow tie appearance, dark areas which are triangular and joined by an isthmus in between. We don't pay much attention to the axial image, but the axial image is vital to look at because it gives you an unfast look at the meniscus. But the danger is that the lateral meniscus and the medial meniscus may not appear in the same planes. So you either have to angulate the patient properly or exercise enough patience to go through all your lateral sections to make sure that the meniscus in question is intact. As you can see on the left-hand side, you see the lateral meniscus, which is nice and circular and is completely intact. Here's a coronal image. On the coronal image, you get to see both menisci, and you can see the nice triangular appearance of both menisci as they are viewed in the coronal image. Now, the MR appearance in the normal lateral meniscus on the coronal image, when you look at the left-hand corner of the slide, you're able to see the meniscofemoral ligament of Risberg and the normal posterior portion of the lateral meniscal root. It's very, very important to look at this because if the root is torn, it becomes obvious here. You may see a discontinuity on this image, but it's not a real tear, because if there was a real tear, fluid in the joint would flow between the Risberg ligament and the posterior root, and you will know that this is disrupted. The mid-knee image will allow you to look at both posterior roots of both menisci, the posterior roots of both menisci. And when you look at the image on the lower right-hand corner, the medial meniscal root is depicted or delineated by a white arrow, while the lateral meniscal root is shown by a left arrow. Now let us consider the pathologic problems which afflict the meniscus, in this case particularly the lateral meniscus. A variety of meniscal lesions are present, but the most or the greater majority of these meniscal lesions are secondary to trauma. What are some of the other pathologies? There may be a developmental abnormality, and the most common is the discoid meniscus, which is really more common in the lateral meniscus than in the medial. Then you have inflammatory processes, infection, neoplasia, metabolic alkaptonuria, and then degenerative changes such as CPPD, PVNS, and synovial osteochondromatosis. All these fall in the category of degenerative and miscellaneous. It is important to remember that by virtue of the fact that there is not much vascularity in the menisci, they are less prone to these disease processes which may affect the synovial tissues or other tissues such as the articular cartilages of the component bones. It doesn't mean they will never be afflicted, but when they do get involved, it's later on in the disease process than earlier on. This applies to all the other pathologic entities other than trauma. Let's look at some tears of the lateral meniscus. Some time ago, radiologists used to classify the signal, increased signal in the meniscus as grade 1 when it is oval or globular but does not communicate with the surface. Grade 2 when it's linear but does not communicate with the surface. Grade 3 are linear signals which do communicate but with either the superior, inferior surface or both. Now this thing has come into some disuse because with the advent of the 3 Tesla MR, you're able to see changes in signal intensity in what you would normally have called a normal meniscus on the 1.5 or 1 Tesla MR. ISOCOS is the International Society of Arthroscopy, Knee Surgery and Orthopedic Sports Medicine. And they classify the tears a little differently. The first system they use is locating it in the coronal plane, anterior, middle, and posterior, or front, middle, and back. The other system describes the location of the tear with reference to the width of the meniscus. Zone 1 is the meniscosynovial junction, which is usually anything less than 3 millimeters from the outside of the meniscus. When the rim width is 3 to 5 millimeters, we are looking at zone 2. And when the rim width is greater than 5 millimeters, we're looking at zone 3. Originally, they used to call this the red-red, which was zone 1, red-white, which was zone 2, and white-white, which was zone 3. This has fallen into disfavor or disuse because the vascularity is significantly different from one patient to another. Here is an example or a cartoon showing the different kinds of tears, and we will discuss this further, but this is a good way to remind yourself of tears. The tear pattern can be longitudinal or vertical and located anywhere along the meniscus. The extension anteriorly and posteriorly may result in a bucket handle tear. The horizontal tear begins at the inner margin and extends towards the capsule. The radial tear also begins at the inner margin and extends towards the capsule, is located at the junction of the middle and posterior thirds of the lateral meniscus, and is based or has its base along the inner aspect of the meniscus and starts to extend towards the outer aspect. What about a flap tear? This may either be vertical or horizontal. The vertical flap extends to the inferior and superior surface of the meniscus, whereas the horizontal flap is an extension of the horizontal tear and extends to the superior or inferior surface. Complex tear, of course, is tearing in several planes. Here is an example of a vertical tear. It's a very, very subtle divot that you are seeing along the superior aspect of the meniscus. And you will notice that there is an area of increased signal intensity below that, which may represent a degenerative change or increased sensitivity of the theta magnet. Now, there is an entity which you must remember here. When you look at examining a meniscus, pay attention to the fluid. In a T2 weighted fat image, you will see that there is a large amount of fluid between the lateral meniscus and the tibial plateau, as shown by the arrow. You should also note the high signal intensity in the anterior cruciate ligament, which is due to tear and contusion of the medial femoral condyle, which is seen on the upper image. But what you're looking at also on the lateral is an elevated anterior horn, which represents the meniscal avulsion, which is a very, very serious problem, and the orthopedic surgeon needs to be involved as soon as you see this floating meniscus. So please remember the floating meniscal sign is a pathognomonic of meniscal avulsion, which is a serious injury. Now here is another tear of the lateral meniscus. In this case, you can see that it is horizontally oriented. Here is another example of a horizontal tear. It extends to the inferior surface, but it's nice and linear. Here is an example of a bucket handle tear where the posterior horn is flipped over the top of the anterior horn. This could be mistaken for a transverse ligament, but you can distinguish it by the absence of the posterior horn. So when you're in doubt, make a careful evaluation of the axials, which may help to clinch the diagnosis. What about a radial tear? Here is a fat-suppressed image showing a full-thickness radial tear right in the middle of that isthmus that I had pointed out when we were looking at normal tears, at normal menisci. Now, the underrated axial view will show you beautifully where there are tears of the meniscus. So here we see an example of the radial tear of the meniscus. And then, when you're looking at a bucket handle tear, notice on the axial view, much better depiction. Why do we not pay attention to the axial views? One, the patient is rarely oriented correctly in the magnet so that you can see both menisci simultaneously. Now, and you get only between 2 to 3 slices on the axial view, whereas you have 13 to 14 slices on the sagittal and coronal planes. The bucket handle tear that I have shown you is actually a medial meniscus tear, but it gives you an idea of how useful the axial view is. Now, let us look at posterior root tear. Conventional spin echo coronal image shows a hyperintense posterior root. See the black arrow? And a complex tear of the meniscal body. There's extrusion of the meniscus, lateral meniscus, which is depicted by the white arrow on the lower image. Lateral meniscus tears are more common than tears of the medial meniscal root and are seen in patients with ACL tears. Extrusion of the lateral meniscus is associated with root tears, complex tears, and deep radial tears. And there is an association with absent medial femoral ligament. So while you are examining the coronal images and you see an absent medial, or you don't see the medial femoral ligament, then you have to be aware that that might be a meniscal root tear. And again, as I mentioned to you, you will be able to see the meniscal root tear really well on your axial image, because you will see a little sliver of fluid going through the tear so that it interposes itself between the meniscal root and the posterior part of the meniscus itself. Here is an example of a full thickness radial tear with extrusion. The black arrow shows a large radial tear, and the white arrow shows the intact medial meniscus. The black arrow shows extrusion on your right-hand side. The black arrow shows extrusion of the lateral meniscus. Let's look at some other pathology. Meniscal cysts. This is a consequence of a long-standing trauma, so you mightn't get all the typical effects or all the typical signs of meniscal tears that you might be looking for. But once you see a meniscal cyst, you have to be alerted that there may be other injuries visible in the meniscus. Now, we had talked about the multiple pathologies of the menisci. Discoid meniscus is a congenital variant and is more prevalent on the lateral meniscus. Watanabe classified this as an incomplete discoid meniscus where the meniscus is larger than normal but has normal attachments. The complete type, which covers the entire tibial plateau and has normal attachments. Although these are prone to injury, they're not as bad as the third type, which is called the Risberg variant. When we discussed anatomy, I showed you the proximity and the attachment of the posterior portion of the lateral meniscus to the ligament of Risberg as well as the capsule. So when you don't have these, it becomes the Risberg variant of the discoid meniscus, causing hypermobility of the lateral meniscus, making it more vulnerable to injury. Discoid menisci are not uncommon, and the criteria for discoid meniscus is when you see it in 3 or more 5 millimeter slices. So you continue to see the continuity between the anterior and posterior horns. When the difference in the heights between the normal and alleged discoid entity is greater than or equal to 2 millimeters, you suspect a discoid meniscus. The discoid meniscus, as I said before, is more prevalent in the lateral meniscus. The mid-body of the normal meniscus should taper and form a triangular configuration of 4 to 5 millimeters at the periphery to becoming paper-thin at the free edge. When this doesn't occur, you suspect a discoid meniscus. It's more common in Asians and also more prone to tear. Here is an example of the Risberg variant of the discoid meniscus. It's a T2 weighted fat image which shows a vertically oriented posterior horn. So as you're proceeding through, you see that the posterior horn, instead of being nicely horizontally oriented, kind of tips forward, and you know that you're looking at something which may be the discoid meniscus, the Risberg variant. As you will recall, I told you that the discoid meniscus of the Risberg type is characterized by the absence of the attachment of the meniscus to its adjacent ligament. And this is the reason why the orientation of the posterior horn becomes vertical rather than lateral. Here are some more examples of the discoid lateral meniscus. As you're proceeding through, you will see that you never really get a paper-thin free edge, and it continues to be like a block rather than a triangular area of load signal intensity. What are the imaging modalities that we use? This is a slide that I took from my previous lecture. You use radiography to look at bone structure, then optical computed tomography for evaluation of articular cartilage, ultrasounds for ligaments and synovium, but MRI for all intra-articular structures and pathology, especially the menisci. And this is important to use menisci because, and MRI, because loss of menisci or loss of integrity of the menisci as well as tears can lead to a debilitating chronic osteoarthritis, leading to bone change and cartilage, bone changes and then cartilage changes, meniscal changes, ligaments, and synovial tissue. I'm sorry about that. I'm showing you the same study before. Again, as I said to you, the Watanabe and Takeda classification, complete discoid meniscus, incomplete, and you have the Risberg variant. So we have discussed now multiple ways of the tears as they present, and the pathology of a meniscal cyst, and the discoid variant. When you're looking at a meniscus, you have to look at its configuration, the signal intensity, bearing in mind that there may be increased signal intensity when you're using a 3 Tesla magnet, and the thickness of the meniscus and the continuity of the anterior with the posterior horns. The relationship